Role of robotic in total knee replacement. We have been doing robotics for last now 2.5 years. And what are our aims in a primary knee replacement? The aim is to get our knees at 90 degrees to the mechanical axis. Obviously, when we are talking about mechanical alignment, not about kinematic alignment, get our tibias at 90 degrees to the mechanical axis again. Get our posterior cuts parallel to the transepicondylar axis, get good patellar tracking and an overall good balanced knee inflection extension with a good rectangular gap inflection extension. So how do we achieve it in normal knees? We do it with a distal femoral cut at 5 to 7 degrees of valgus with a good intramedullary jig with an intramedullary rod. Tibia at 90 degrees to the mechanical axis with an extramedullary rod in majority of the times and a posterior condylar APCC cut with 3 to 5 degrees of cut with a different type of jigs provided by different companies with the sizer with 3 to 5 degrees of external rotation as seen in these pictures. So how do we achieve it? With patients who have osteoarthritis knee with bilateral total hip replacement where you are not able to going to put a rod inside the femurs, or patients who have a deformity like this who has a varus knee healing with a rotational malrotated femur and a retroward femur, or a patient who has undergone a shaft femur fixation or a patient who has undergone a distal femoral fixation. So the answer for that problem is robotic, or in previous cases was navigation. So how do navigation or robotics help in these cases is to establish the center of head, center of ankle and center of knee. It also establishes the center of identifies the epicondyles. Then you morph the bone, the knee, the condyles and the tibia. Then you balance the knee preoperatively before you actually cut the knee, and then without removing the implants either intramedullary or extramedullary, you go ahead and do your knee replacement. I thank my dear friend Dr. Nikhil for giving me this video on a very short notice. This is a video of navigation or robotics which doesn't use images. So this is imageless robotics by Corey. So this is a very short video of showing you how do we establish the center of knee and center of ankle and center of hip. So this is where you see, I'll pause that in between. This is where you see whether you have established the center of, center of the knee by putting trackers. Then you put the center of the ankle, then you go ahead and get the center of the knee and then rotate your femur in such a way that you have established the center of the ankle. And once you have done that, you take the knee through a range of movement, and once you have done that, you negate the possibility or requirement of putting in a rod for an intramedullary jig and getting your distal femur at 5 to 7 degrees or whatever degrees that you wish to do in that particular case. And there is no need of putting in a rod. So a patient who has undergone a hip replacement, you no more need a rod inside the medullary canal, or patient who has intramedullary nail, you don't have to go ahead and do a rod. In a similar case, after doing this, you do a morphing of the femur and the tibia and you do sizing. The second video that I am going to play is for image-based navigation, image-based robotic, where you have a preoperative image already fed to the robo, and this preoperative image is actually morphed intraoperatively with points which are predetermined previously. Now these points are predetermined on the PC and you just take them on intraoperative with the help of a probe, and there is something called as an RMSE or root mean square error. So this root mean square error has to be less than 10 in the initial phase. So the whole root mean square error is less than 10 millimeters and the final root mean square error has to be less than 1 millimeter. So the precision comes down to 1 millimeter square. So you need to take only 40 points on the femur and 40 points on the tibia, which takes not more than at the most 3 to 5 minutes for the whole morphing of femur and tibia. And once that morphing is done, again the need for doing an intramedullary rod is done. By doing this, you can see that I am taking the morphing, I am doing the morphing on the tibial tubercle, I am doing the morphing on the upper end tibia, and once that morphing is done, you get your RMSE. You can see that initial RMSE was 5.3. So once that 5.3 is done, you are less than 10 millimeters of RMSE. You take the 5 points on medial side, you take 5 points on the central portion of your epicondyle or central portion of your tibia, 5 points on the lateral portion of your tibia, and then you have 10 points on the anterior side. So once you are used to taking these points, I can assure you the whole time taken is not very high. It's usually around 5 to 7 minutes at the most. So once this morphing is done, then you go in and do something called as gap balancing. So once that gap balancing is done, you can adjust your femoral rotation, you can adjust your distal femoral cut, you can adjust your tibial angles, and you nullify the possibilities of using any jigs or passing any intramedullary rods, and thereby even if you have intramedullary implants or extramedullary implants, the possibility of using your primary knees is increased. So robotic helps to determine the mechanical axis without entering into the medullary canal by determining the center of the hip, center of the knee, and center of the ankle. It also helps you to increase or decrease your femoral sizing to get the perfect balance in flexion extension. You can rotate your femur to get your balancing correct in flexion extension, and you can increase your tibial tibial cut to increase your gaps to get the perfect balance. That's just two cases for you. That's the case that I have shown you, where you have a mal-rotated femur with recurvatum deformity and a varus, where you have a broken screw or a broken drill bit previously with a primary femur with robotic surgery done, and a distal femoral stem or fixation plate, where again we have used high speed burr, where we have cut the distal femur and used a small stem to the primary femur to protect whatever is the healing bone here, and we have used a primary femur with a use of a robotic knee replacement. With that, I thank you for your patient hearing.